Okay, so last but not least, we have Peter Gloviczki, and Patty and I are fighting over who gets to introduce him, and whenever Patty and I are fighting, she always wins.
No, that's not true. I want to, I'm very gratified and thank Dr. Gloviczki for being here with us, because he and I have been on every continent in the world. We've been at meetings since the late 1980s. And it's such a pleasure to have him be at our meeting this year. Thank you very much.
Thank you very much, Patricia. It's a real pleasure to be here, and congratulations, Dr. Amaya, for this great meeting that honors Dietrich. I'm happy to share with you a few thoughts about the paper that we published recently that is a new reporting standard for stenting chronic iliofemoral venous obstruction. Iliofemoral stenting has been around now for over 20 years. Dr. Neglan and Dr. Raju published a seminal paper in 2007. That was an amazing paper of close to 1,000 patients with 5-year results, 100% patency of primary and 96% patency, secondary patency of post-thrombotic patients. And that certainly stimulated a lot of interest. And as you can see here, multiple guidelines during the past a decade or so, 15 years, to try to define really when should we do iliofemoral venous stenting and what's the best technique to do that. Unfortunately, the guidelines are just about as good as the underlying data. And the data are very important to provide high-quality evidence to the guidelines, because otherwise we are really relied on single-center retrospective studies or maybe prospective cohort non-controlled studies. Randomized controlled trials have been rare, unfortunately, in the field of iliofemoral venous thrombosis. But Patricia Thorpe certainly was a pioneer in this field and organized this study from this institution here. It was a prospective randomized study, 51 patients with advanced disease. Half of the patients were randomized to best medical treatment, half of them have stents. They actually evaluated the patients at 6 months and showed that there was significant improvement, at least statistically, in the stented group. The only other prospective randomized study that came out last year is this German study by Human Jalai, who had a 63-patient study with a follow-up of 3 years. Unfortunately, the enrollment was not very good, and the study had to be stopped because of COVID. But they too were able to show that there was statistically significant difference in quality of life in patients who underwent stenting. Unfortunately, the between group difference was lower than the pre-specified clinically relevant quality of life difference that they defined in 14 points. So again, we do not have high level of evidence that this is better than any of the medical treatment. We have some additional evidence. This comes again from Dr. Raju's group that shows that the newer dedicated stents perform at least as well as the wall stent and Z-stent combination. This was a Delphi consensus that we worked on with Suresh Vedantam and several experts, mostly from the Viva, 5 vascular medicine doctors, 13 vascular surgeons, 6 interventional radiologists, and 3 cardiologists, clearly a multidisciplinary panel. And the reporting standards are so important to really have good data in your clinical studies. And that's why we thought that this is important, that we have internationally accepted reporting standards where the follow-up is similar, where the safety outcome and the efficacy outcomes are also similar. That's where we try to come to a consensus of the experts. The general consensus statements were that the design has to be rigorous, and we thought indeed that still RCTs, in spite of all the limitations that we talked about this meeting, and in spite of the artificial intelligence that clearly is going to change data collection and assessment, RCTs still provide the highest level of evidence to assess outcome due to stent placement unrelated to the natural history of the disease, to conservative treatment or co-interventions. The outcomes have to be defined well in advance, both primary and secondary. Qualifications of the investigators must be described. Study has to be registered and posted. The other statements were that standardized study populations are important. We really shouldn't compare primary to post-thrombotic disease, and obviously gender, race can play a major role. Symptoms and disease severity should be well described. The state of all endovascular methods have to be described to be sure that it is the stenting that causes the improvement, type of stent, whether it is covered or uncovered, or different sizes have to be described, and adjuvant medications. We believe that IVUS and multiplanar venography are the best ways to assess the anatomy and size the stent and decide for the treatment. The length and completeness of the obstruction should be clarified, occlusion of and percent of the stenosis defined, and the relevant cardiovascular factors, BMI, described. These are the safety outcomes: successful stent deployment, freedom from early complications, stent-related late complications, and we believe that these studies should have at least a 3-year follow-up, because late complications of the stent have occurred in published studies. Efficacy outcome measures, patient-centered sequelae of venous disease, clearly a VCSS, Villalta score, and disease-specific quality of life measures should be used. If patients have ulcers, that is a very well-defined outcome measure. And then the validated scoring system, quality of life measures are preferred over measurement of individual signs and symptoms. And we learned from the ATTRACT trial that the use of continuous measurements are better than non-continuous measurements. So the take-home message really from this paper that I recommend you to read is that uniform reporting standards should be adopted by national and international societies to aid standardization and increase the quality of reporting clinical outcome of endovascular interventions performed for chronic iliofemoral venous obstruction. This field is going to grow, it's going to change, dedicated venous stent scope, and again, in the assessment, artificial intelligence will help us to define what's the best treatment for iliofemoral venous obstruction. Future is bright, but it's not what it used to be. Thank you.